Good afternoon and welcome to today's webinar, Immigrant Health, the Role and Impact of Medicaid, HIPAA, and the Public Charge Doctrine, brought to you by the Network for Public Health Law and the American Society of Law, Medicine, and Ethics. I'm Charles Chong, the Digital Marketing Coordinator at the Network for Public Health Law's National Office, and I'll be your host for today's webinar. The presentation slides and video playback for this webinar will be available on the Network for Public Health Law's website shortly after the conclusion of this event. We strongly encourage attendee participation in our webinars and would love to hear some of the thoughts that you have. So please feel free to submit questions at any time by using the Q&A tab on the right-hand side of your screen. So all you need to do is click on that tab, select all panelists from the drop-down menu, and submit your question. Your moderator for today's webinar is Carrie Lowry. Carrie is the Deputy Director and Director of Grants and Research at the Network for Public Health Law's Eastern Region Office, where she provides legal technical assistance on a variety of health topics. Her current work focuses on empirical legal research and coding, injury prevention, and child and adolescent health policy. Carrie will be leading us through the rest of today's webinar. So Carrie, over to you.
Thank you, Charles, and good afternoon, everyone. On behalf of the Network for Public Health Law's Eastern Region, I just want to thank you for taking time out of your day to join us today for this important webinar. The title of our webinar today is Immigrant Health, the Role and Impact of Medicaid, HIPAA, and the Public Charge Doctrine. We have three great speakers lined up for you. It's a culmination of a semester's worth of work for the law students who will be speaking with you. And we feel like this is information that's very important to pass along to folks, especially in this political climate. So first, you will hear from Priscilla Huang. She is Senior Attorney in the National Health Law Program's Los Angeles offices. Priscilla has a background in reproductive justice, racial and ethnic health disparities, and immigration health care access. Prior to joining the National Health Law Program, Priscilla was a consultant and senior advisor with the White House Initiative on Asian Americans and Pacific Islanders, where she spearheaded various federal interagency efforts on improving language services and data collection and reporting. Then you will hear from Laura Macchiarelli. Laura is in her third year of law school here at the University of Maryland Carey School of Law. Prior to law school, Laura worked in a healthcare consulting setting, primarily in pharmaceuticals. She received her Bachelor of Science from the University of Maryland College Park and her Master's of Public Health from the George Washington University. Laura's areas of interest include food and drug law and regulation, health policy, and immigration health. And finally, you will hear from Dorothy Singletary. Dorothy is a third-year student also here at the University of Maryland Carey School of Law. She graduated from the University of Maryland in College Park in 2016 with a bachelor's degree in government and politics. And during her time here in law school, Dorothy was a Peggy Browning Fellow at the Los Angeles Black Worker Center, interned with the U.S. District Court Judge Ellen J. Hollander, and she clerked at a D.C.-based employment law firm. After graduation, Dorothy will be working at the IRS in the Income Tax and Accounting Division, and Dorothy's areas of interest include employment discrimination, civil rights, and income tax law. So without further ado, I'm thrilled to present to you Priscilla Huang.
Thank you so much for that introduction. Hello, everybody. This is Priscilla. I am really pleased and excited to be presenting with an incredible lineup of panelists to talk about this really important issue. Many thanks to the Network for Public Health Law for inviting us to participate. So I'm going to talk really briefly and go through some of the immigrant eligibility rules for people who want to enroll in Medicaid, and then move into the Public Charge Doctrine, both the current rule as it stands and also what's being proposed under last October's proposed rule, and some of the potential harmful impacts that it will have on immigrant communities and families. So first, looking at immigrant eligibility, in general, after 1996, with the Personal Responsibility and Work Opportunity Reconciliation Act, or PERORA for short, that essentially redefined eligibility for immigrants by creating two categories of immigrants for federal benefits. Those federal benefits are means-tested benefits and includes Medicaid, and those are defined by statute. And so essentially you have the categories of a qualified immigrant. You can see the list on your slide, which includes LPRs, which are legal permanent residents, or green card holders, refugees, asylees, et cetera. And then basically anybody who is not enumerated under the qualified category is considered not qualified for federal means-tested benefits, including Medicaid. I did want to note that the rules are different for emergency Medicaid. Essentially, anybody who, whether you're qualified or not qualified immigrant, including undocumented immigrants and individuals with DACA status, are able to receive limited services in emergency situations. And so the analysis for immigrant eligibility actually doesn't stop at the qualified status. There's actually two more steps to consider when thinking about immigrant eligibility. So in addition to having a qualified status, there are some qualified immigrants who are subject to what's known as the FiveYear Bar, and some who are exempt. And the FiveYear Bar is also something that was introduced in PERORA. Essentially, it pertains to the immigrant categories you see there: LPRs, battered immigrants, individuals paroled into the U.S. who entered the U.S. on or after August 22nd, 1996. Those individuals have to wait at least 5 years in order to become eligible for Medicaid. And then for qualified immigrants who are exempt from that bar, and so those are victims of trafficking, refugees, asylees, and certain other humanitarian categories, those are exempt from the FiveYear Bar, and so they may receive services and coverage immediately once they're of that qualified status. Just a note that there are also some immigrants who may have physically entered the U.S. before that August 22nd, 1996 date and remained in the U.S. continuously until obtaining a qualified status. Those are not subject to the FiveYear Bar. So just to add even more complexity to the eligibility rules for Medicaid and other federal means-tested benefits, there are also state programs that cover slightly expanded categories of what are known as lawfully residing immigrant children and pregnant women that have also taken an option that was made available in 2009 under the CHIP Reauthorization Act to also cover qualified immigrants without the FiveYear Bar. So you'll notice there's a change in language here. Under this broader category, the lawfully present immigrants who are residing in these states, they can enroll in Medicaid or CHIP, and as long as they meet this definition, which includes all of the qualified categories, but also includes a few more immigration categories. So some examples include individuals with TPS or temporary protected status, some individuals with employment authorization, COFA migrants. Those are people who come to the U.S. From the Compact of Freely Associated States, such as the Micronesia and the Marshall Islands. Those individuals are actually included in this coverage category. As of January of this year, 33 states and D.C. have taken up this option for immigrant children, and 24 states and D.C. have taken up this option for pregnant women. There are also a handful of states, 6 states and D.C., that provide coverage to children regardless of immigration status using state-only funding. And then California last year expanded their Medicaid program to include coverage for young adults up to age 26. So just a quick summary of all of the different layers of immigration eligibility. First, you want to just take a look at the federal minimum, whether that person is of qualified status, whether they're subject to the FiveYear Bar, or whether they might be exempt. Then you can take a look at which state that person resides in, whether they might have that additional federal option of being a lawfully residing child or pregnant woman, not being subject to FiveYear Bar, and being in those states that have taken up those options. And then even in addition to that, the states that have gone all the way and provided coverage for all of their residents regardless of immigration status. So with that in mind, there certainly have been a lot of gains in the last decade in particular to really expand coverage for immigrants under Medicaid, and that should be something to be celebrated for sure. We have a number of challenges, unfortunately, right now with this administration, and a big one is proposed changes to the Public Charge Doctrine. So I'm going to spend the next few slides walking through this. Public charge, just to start off, is a term that's used in immigration law to describe someone who is likely to become primarily dependent on government assistance. I'm going to dig into that a little bit more in a minute, but I did want to note that many of the slides that you'll see in this section of the presentation come from the Protecting Immigrant Families campaign, which is a joint effort by the National Immigration Law Center and the Center for Law and Social Policy. We sit on the steering committee as a member, and they produced much more visually appealing slides than I did, so I am using them. So just to walk folks through what is under the current public charge test, there are basically three main features for how public charge works today. You'll see the definition of public charge is a person who is likely to become primarily dependent on the government for subsistence. You'll see in that language, the likely to become indicates that this is a forward-looking test, it's a prospective test, and it can't be based on what types of benefits may have been received in the past. The next kind of category in the public charge assessment is, under the current rule, is whether it falls under the two types of benefits that are currently considered, and those are cash assistance for income maintenance, that's TANF, for example, SSI or other general assistance funds. And then the other category of benefits is whether that person is likely to be institutionalized for long-term care at government expense. So that's an example of that could be residing at a nursing facility using federal funding for that. And then the last category that's considered in the current public charge test is whether taking a look at what's called the totality of circumstances of this individual, taking into account age, health, family status, financial status, education, and skills. The immigration official will take a look at all of these things and without considering one over the other, really look at the individual circumstances as a whole to consider whether they might be likely to become a public charge. And just a quick note on the affidavit of support. In current practice, oftentimes having a valid affidavit of support, which is essentially a binding contract where a immigrant seeking to either enter or adjust their status will have a sponsor. The sponsor is oftentimes a family member or possibly an employer, will commit to providing support for that individual if they would need assistance. Traditionally, that has been enough to avoid a negative public charge determination. And so the other piece to remember is who this applies to. So the public charge test comes up in mostly under two circumstances, and in a narrow, a much narrower sense, a third category. But in the two main ways, it applies to when an individual is seeking to enter into the U.S. with a visa, or that individual is already in the U.S. and they're applying for a green card. So oftentimes they are in a non-immigrant visa status and applying to seek permanent residency and seeking a green card. It's important to keep in mind that there are some individuals who might already be living in the U.S. And in order to seek the green card, part of that process requires them to leave the U.S. and return to their country of origin in order to apply. And then the third category is there are people who are green card holders who are already permanent residents. If they leave the country, the U.S., for more than 6 months consecutively, they will have to be subject to a public charge determination when they try to re-enter. It's, I think, even more important to understand who is not subject to a public charge determination. There's been a lot of confusion about this, and this has caused a lot of fear and contributed to a lot of the chilling effects of this rule. It does not apply to all immigrants. So there are a lot of exempt categories, such as refugees, asylees, people fleeing domestic violence. You'll remember that these are many of the categories that are also Medicaid eligible and not subject to the FiveYear Bar. And so these exemptions are in statute. They cannot be changed through regulation and would require an act of Congress in order to change that. It also does not apply to somebody who is seeking to naturalize to become a U.S. citizen. So there's been a lot of confusion about that as well. So please know that the public charge test does not come in that circumstance. So now I'm going to shift us into doing a quick overview of what has been proposed as changes to the public charge test. And so you'll remember before I talked about the current definition, the totality of circumstances test as it's currently applied, and the two main categories of benefits that are considered. Under the October 2018 proposed regulation, there are proposed changes to all of these areas, and really quite sweeping changes as well. So let me walk us through those. So on the definition of public charge, remember that the current definition states that a person who is likely to become primarily dependent on the government for subsistence is the current definition. The proposed definition is, as you can see, an immigrant who receives one or more public benefits. So this is significant for two reasons. First, the likely to become primarily dependent language is no longer there, and the dependent on government for subsistence has also changed. And the reason that's significant is because that language makes clear that a person will only be considered a public charge if they are relying on the benefits as a main source of support. And usually that's cash benefits, such as the TANF and SSI. The proposed definition is a big shift from that because now what it suggests is that an immigrant who merely supplements their current income with cash or other non-cash, specifically non-cash benefits, would actually be subject to, would actually potentially meet the definition of public charge. And so that is a big change. turning to the totality of circumstances test. So there are a number of very detailed changes and proposed new criteria that are set forth in the proposed regulation. Just to highlight a few, so you still have many of the same 5 factors that I mentioned earlier, except now there are more specific criteria and statutory factors that are regulatory factors that'll be taken into consideration. So around age, for example, either being too old or too young could negatively affect somebody, so an applicant who's either under 18 or over 61 years old, having a health condition that could affect their ability to work, attend school, or care for themselves, or might require expensive care. This is would actually be weighed heavily against the applicant if they can't show that they have private health insurance or the resources available to cover that type of care. So that's also a new criteria. There are new income tests that would also weigh heavily in the determination. And then whether somebody has English proficiency, that can be factored in as an education or skill. In addition to those new criteria, the proposed regulation also seeks to introduce a new system of weighting certain factors. So you'll see kind of on the right-hand side those very heavily weighted negative factors, such as the receipt of public benefits, the health condition criteria I mentioned, the lack of a job or job prospects. And there's only one heavily weighted positive factor, which is having an income of 250% or more of the federal poverty level. So, and then on the third category of changes for the public benefits rule, you'll see here it greatly expands the types of benefits that could be included. So the 2 boxes in green or teal on your screen that says cash support for income maintenance and long-term institutional care, those are the current categories, so those have not changed. But in the proposed rule, they've added 4 additional categories of benefits that could be considered. You'll see non-emergency Medicaid is one of them, Medicare Part D, low-income subsidy, SNAP or food stamps, and certain housing assistance, specifically public housing or Section 8 housing vouchers and rental assistance as benefits that could be considered. So these are also big changes. Just to narrow in on the Medicaid pieces, there, as I mentioned, the proposed rule really seeks to expand the types of benefits that are considered. You'll see those listed in the gray box. And then it expands the types of benefits that could be, it also lowers that threshold for public benefit use. So remember, in that shift in the definition, we go from looking at somebody and assessing them for the public charge determination as a main source of support versus looking at their benefits receipt as merely a supplement. And then the various new criteria and weighted factors that will come into play with the totality of circumstances test. So this obviously has really big impacts on immigrant families and immigrant communities. There's actually really great data that I won't go into, but that is available, and I'm happy to share with folks who are interested, that show, potentially this has a huge impact and disproportionate impact on people with disabilities or medical conditions, women, children, older immigrants, and immigrants of color. There's also already been a number of reports in the media and surveys that have been conducted by organizations and community groups that show, even though this rule has not been finalized, it is still only a proposed rule. It has already caused a lot of fear and confusion among immigrants. and disenrollment is actually already happening in several programs and has been reported in several states. Specifically for Medicaid and CHIP, this is a, apologies, it's kind of a fuzzy graphic here, but there's a slide that is taken from a estimate that the Kaiser Family Foundation conducted last fall. They found that looking at disenrollment, potential disenrollment rates at basically ranging from 20 to 40%. There are potentially 14 million Medicaid and CHIP enrollees who live in a household with at least one non-citizen. Half of these enrollees are actually citizen children, and as many of us who do work in this area or work with immigrant families know, when something impacts one person in the household, it often has a chilling effect on the entire household. And with that, I am going to pass it on to Kathy. Thank you.
Great, thank you. Actually, so this is Kathy Hoke. I'm the director of the Eastern region of the Network for Public Health Law, and I am turning it over to two of our third-year law students so that they can do the hard work. So first you're going to hear from Dorothy Singletary, and then you hear from Laura Macarelli.
All right, hello everyone. My name is Dorothy Singletary, and I will be presenting today with my colleague Laura Macarelli. And so we'll be discussing patient privacy laws and how they relate to immigrant patients. So just to give you guys a little bit of background, first I'll be discussing a little bit of why we started looking into this project. And so originally we received an email about a family in crisis. So the father was picked up by ICE in front of his wife and children. When he was picked up, part of the paperwork that immigration officials had was from a medical clinic where he was seeking treatment for his diabetes. There was concern that this would discourage the rest of the family to not seek medical care. So based on that email, we really want to outline the rights and responsibilities that are found under patient privacy laws, because we want to remove any misconceptions or barriers that are stopping immigrant patients, particularly undocumented immigrant patients, from seeking medical care that they need. And we're looking at this really from a public health law perspective, in the sense that when one person is not seeking medical care for themselves, it not only impacts them, but it also impacts others that they come in contact with. So in a lot of cases, we see that there are mixed status families, and that's generally where, say, a parent is an undocumented immigrant, and their children may have some type of status, like such as documentation status, or are U.S. citizens. And so, however, the whole family may not seek medical care because they're afraid that something similar to what occurred in the email, where maybe the undocumented immigrant relative will, their information will be passed along to immigration officials and they'll face deportation. And so that issue does not only just impact their family members, but it also impacts the people that they interact with within their communities. And that's even something we're seeing now across America with the measles outbreaks, where maybe one person isn't seeking medical care for themselves or for their family members, and that has huge ramifications for others. And so in this presentation, we'll be looking again at both federal as well as state legislation and policies that discuss patient privacy rights and laws. So just to give an overview of what we'll be discussing in our presentation, first, we'll be looking at what is HIPAA and how does HIPAA protections extend to undocumented immigrants. Then we'll be looking at when can medical providers disclose a patient's protected health information to law enforcement. In the middle of our presentation, we'll be pivoting and looking at what are some limits on immigration enforcement at health centers. So we'll first look at protections found under executive agency memos, and particularly we'll be looking at the sensitive location policies. Then we'll look at protections found under the Fourth Amendment. And then lastly, we'll look at state privacy rights. So now I'm actually going to turn it over to my colleague, Laura Macarelli, and she's going to discuss what is HIPAA and how do those protections extend to undocumented immigrants.
Hi, my name is Laura. So first we'll start with what is HIPAA. HIPAA protects PHI by restricting covered entities from disclosing patient information. and these covered entities include health plans, healthcare clearinghouses, and most of you today will fall into the third category, which is healthcare providers who transmit any health information in electronic form. So when wondering if HIPAA applies to your undocumented immigrant patient, it is important to remember that HIPAA applies only to PHI and not to the person. Therefore, any information you gather and maintain about the patient is protected by HIPAA. So what is PHI? PHI is any information that pertains to a patient's past, present, or future physical or mental health condition, or the past, present, or future payment for the provision of health care to the individual, and information that identifies the individual. So common PHI includes names, birthdays, and addresses. So does HIPAA protect patients' immigration status from being disclosed by medical providers? Immigration status is considered PHI if it is disclosed along with other identifying information about the patient and relates to the patient's health condition or payment for health care. However, immigration status alone is not enough to be considered PHI. So if a medical provider believes that a patient may be undocumented because, for example, they used an expired passport as identification and later told a law enforcement agent that a patient was undocumented, then this would not be considered a HIPAA violation. But if the doctor tells a law enforcement agent about his suspicion that a specific patient who was seen at the hospital is undocumented, along with identifying information such as the patient's name or current address, then the patient's immigration status would be considered PHI, and this would be a HIPAA violation. In what circumstances can a medical provider disclose PHI without a patient's permission? So HIPAA allows for various instances where disclosure is permitted without permission. However, for the purposes of today, we're only going to focus on 3 of the most relevant circumstances: court orders, crimes committed, and administrative requests. So the first exception is court orders. And a court order means any order, subpoena, or summon issued by a federal judge or immigration judge. It's important to remember that these orders are different from the orders issued by ICE. This is because an ICE warrant does not require the showing of probable cause, and also no court is involved. So ICE orders are not covered by the exception of status. If you disclose information because you receive an order from ICE, you've committed a HIPAA violation. However, if a medical provider receives a subpoena or order from a federal judge or immigration judge, first check to make sure that the order is valid by ensuring it is dated, is signed by the judge, includes the address of the medical center, and includes the items or persons being ordered. If any of this information is missing, you have the right to refuse to comply. Please keep in mind that immigration judges often do not issue an order to request PHI information. This is because by the time the immigration judge hears the case, the immigration status of the patient is already available.
All right. So the second relevant exception is that a medical provider may disclose a patient's protected health information to law enforcement if they have a good faith belief that the information constitutes evidence of a crime committed on the premises of a covered entity. So a big question we usually get when we get to this slide is, so say a medical provider is seeing a patient who happens to be an undocumented immigrant, do they have some type of affirmative duty to contact immigration officials, or is it a crime for even the undocumented immigrant to be present on the premises of the covered entity, such as a hospital or a doctor's office? And the answer to those questions are no. So when an undocumented immigrant enters into the country without proper authorization, that constitutes a crime. However, it is not a crime for an undocumented immigrant to be continuously present within the United States. When an undocumented immigrant is, say, on the premises of a hospital or at a health clinic and they're being seen by a medical provider, that does not constitute a crime committed on the premises of a covered entity. Additionally, there is no affirmative duty for a medical provider to release a patient's protected health information, particularly even their immigration status, to immigration officials. And so the third relevant exception is that a medical provider may disclose a patient's protected health information if they receive an administrative request. So an administrative request includes an administrative subpoena, an investigatory demand, or other written requests from a law enforcement official or administrative agency. So an administrative request must be accompanied by a written statement saying that the information requested, it is relevant, specific, limited in scope, and it's only asking for de-identified patient information. So what is de-identified patient information? It is information that does not identify or readily identify the patient. So that includes the patient, their name, their address, social security number, passport number, so anything that can readily identify them. And so before we move on to our next section, I just want to do a quick recap of the 3 exceptions we just went over. So again, a medical provider may disclose the patient's protected health information if they receive a court order, a warrant, a subpoena, or a summons. Things to look out for when you receive one of those things include checking to make sure the date is correct and that's not expired, looking at the location, making sure it's the correct location, 3, looking at the items or person to be searched or seized, and then lastly, looking at making sure it's signed by a judge. If any of those things are missing, then it's not valid, and you do not have to honor the subpoena or warrant. Additionally, a medical provider may disclose the patient's protected health information if it constitutes evidence of a crime committed on the premises of a covered entity. We now also all understand now that when a medical provider is seeing an undocumented immigrant, say at a hospital or at a clinic, that does not constitute evidence of a crime, and that they have no affirmative duty to contact immigration officials. And the third relevant exception is that a medical provider may disclose a patient's protected health information if they receive an administrative request. And so the information that, if you do respond to an administrative request, should only be de-identified patient information. So it should not be releasing a patient their name, their address, their social security number, passport number, nothing that can identify or readily identify a patient. So now we'll be looking at what are the consequences for violating HIPAA. So HIPAA is enforced by the Department of Health and Human Services through their Office of Civil Rights. So it's enforced through a series of fines, penalties, as well as a medical provider can face years of imprisonment for violating HIPAA. There is no private cause of action under HIPAA. So that means that no individual patient can actually sue a medical provider who violates HIPAA. However, they can also still file a complaint, say, with a medical licensing board, and that can affect a medical provider's licensing. One big question that we usually get at this stage is, so what happens, say, if a medical provider does violate HIPAA and they provide a patient's protected health information to law enforcement officials? Can that information still be used at a patient's deportation hearing? And the answer is yes. So any protected health information shared in violation of HIPAA can still be used at a patient's deportation hearing. And this is because a patient's deportation hearing would be a civil proceeding, so it does not have the same protections as would, say, a criminal proceeding would have. However, again, there are still relevant avenues that an individual patient can pursue in order to hold a medical provider accountable for violating HIPAA. And again, that can be through filing complaints with the state licensing board, as well as they're also held accountable through the Department of Health and Human Services Office of Civil Rights. So now we'll be pivoting a little bit and looking at limits on immigration enforcement at health centers. So first we'll be looking at this executive agency memo, and particularly the sensitive location policies put out by ICE as well as the United States Customs and Border Patrol. And so under the sensitive location policy, it discourages or limits immigration enforcement action by immigration officials at sensitive locations. So what is a sensitive location? A sensitive location includes a hospital, doctor's office, any accredited health clinic, as well as any urgent or emergent healthcare center. So what type of activities are discouraged at sensitive locations? Well, that includes arresting, interviewing, searching, and performing surveillance for immigration purposes. Now, there are exceptions to the sensitive location policies, which include prior supervisory approval, as well as if there's any imminent risk to the public safety, there's a dangerous felon on the premises, or say even if there's a risk of destruction of property that constitutes evidence of a crime. It is important to note at this stage that any information found in violation of the sensitive location policies can still actually be used at a patient's deportation proceeding. As I stated before, a deportation proceeding is a civil proceeding, so it doesn't necessarily have the same protections as would say a criminal proceeding. Now, if you witness a violation of the sensitive location policy, it's still important to file a complaint at the Department of Homeland Security. And this can be easily done by going onto the internet and typing in Department of Homeland Security complaint form, and that should pop up for you. And there, you want to include in your complaint form your contact information, such as your name, and a way for them to contact you. 2, you also want to include a description of what occurred. So you want to include the date, the time, the location, as well as any witnesses. And also you want to include any documentation as well. And so that is kind of a review of what's the central location policy and how it protects limits on immigration enforcement and health centers. And so now we'll be looking at protections found underneath the Fourth Amendment. So the Fourth Amendment protects against unreasonable searches and seizures. The reasonableness of a search depends on whether or not a person has a objective and subjective reasonable expectation of privacy in the areas searched. It is likely that a person will have a reasonable expectation of privacy, say, within a medical examiner's room, so where only the doctor and the patient have access to, compared to, say, if it's just in like a waiting room where anyone in the hospital has access to. However, there are internal policies that hospitals can put in place to make sure that a patient has heightened reasonable expectation of privacy in waiting areas. So those provisions or measures include, 1, roping off that area, making sure that not many people have access to it. You can also place signage around the waiting area and saying only patients and the people accompanying them can have access to the waiting area. Now, what happens if a person has a reasonable expectation of privacy? Well, a warrant is required if that is the case. And so, again, I want to bring you guys back to, and I'm showing here what a sample of a warrant would look like. And so there, again, you want to make sure that the date is correct on it, make sure that it's not expired. 2, you want to look at, see if the location on the warrant is correct, so it's the correct hospital or medical center. 3, look at what is the person or place that's being searched or seized. And then lastly, seeing if a judge's signature is included on the warrant. If any things are missing or that they're incorrect, then the warrant is not valid, and so you should not consent to allow them to search or seize anyone at your location. It's also really important to note as well that any information that's found in violation of the Fourth Amendment can still be used at a patient's deportation hearing. Generally, under the Fourth Amendment, there's an exclusionary rule that would generally exclude this information from being used at a criminal proceeding. However, as I stated before, this is a civil proceeding. A deportation proceeding is a civil proceeding, so it does not have the same type of protections as would, say, a criminal proceeding. And so now we'll be looking at protections found under state patient privacy laws. And so it's important to note that every state will have varying patient privacy laws, and that's important to look up. And the good thing about state patient privacy laws is that even though there is no private cause of action under HIPAA, there may be a private cause of action under a state patient privacy law. Additionally, there are other remedies that an individual patient can look for, which also includes state tort claims. So a patient can also bring state tort claims against a medical provider who violates HIPAA or any other patient privacy laws. So they can bring negligence claims, invasion of privacy claims, or breach of doctor-patient relationship claim as well. And even though there is no individual remedy under HIPAA, the good thing is that they will use the HIPAA standards generally to establish these claims, and so there is still a remedy for individual patients. Additionally, a patient can also still bring, say, a complaint with a medical licensing board as well, and that can also affect a medical provider's licensing. And so now we'll just be doing a quick recap of what we went over. So again, as I stated before, there is no individual remedy under HIPAA, but patients can still sue under state patient privacy laws as well as state tort claims. Additionally, they can still file complaints with medical licensing boards. There are limits on immigration enforcement at healthcare centers. So as we saw, the sensitive location policy that limits certain types of immigration enforcement at hospitals or health clinics. And that type of enforcement that's limited includes arresting, investigating, any surveillance for immigration purposes. Additionally, there are protections found underneath the Fourth Amendment. And so the Fourth Amendment essentially, it protects people from unreasonable searches or seizures. And so when a person has a reasonable expectation of privacy, that means that a warrant will be required. And so again, you want to check to make sure that it is valid by checking the date, making sure it hasn't expired, looking at the location, making sure that it's correct, as well as looking at the person or place to be searched or seized, and then lastly, making sure that it was signed by a judge. If any of those things are missing, then it is not valid.
So all identifiable information provided to medical center staff for the purpose of providing health care is protected under HIPAA. This includes, but is not limited to, name, birthday, address, nationality, place of birth, and in some cases, immigration status. And that's all. That concludes our presentation today, so thank you very much for taking the time. Does anyone have any questions? Carry on. Oh,
Great, thank you so much, everyone. As Charles said at the beginning, if anybody has a question, please feel free to use the Q&A box on the bottom right-hand side of your screen. I will be taking questions from there because all the participants, attendees rather, are muted. So the first question is for Priscilla. Priscilla, the question is there any research showing that the 5-year bar actually saves healthcare costs for states? So, for example, reduces emergency room visits?
Mm-hmm. I would imagine so. I have not tried to look for that myself, but I remember being on the Hill during CHIP reauthorization in 2009 and advocating for what this is called the IKEA Option, and there were certainly data and research that that shows accessible, increased access and coverage to healthcare services saves costs, saves on healthcare costs. It saves, it reduces the cost of emergency room visits, as the person mentioned. We know that timely access to prenatal care obviously has both short and significant long-term benefits, both to the health of the child and the mother, the parent, but also in saving in healthcare costs and preventing other types of illnesses and all of the whole range of, I think, arguments that many of us have used to try to increase coverage or services for underserved populations. I think all of that applies.
Great. And just a follow-up question for you, Priscilla. Is WIC included in the benefits that are, weighed against immigrants? So either in the current iteration of the Public Charge Doctrine or in the proposed rule?
Mm-hmm. That's a really great question. That's another area where there's been confusion. So WIC is not specifically included in the proposed rule, is certainly not included in the current public charge assessment. Remember that the rules around that pertain to cash assistance and long-term institutionalization of care. However, there has already been anecdotal evidence and also, I think, some surveys and reporting actually from WIC agencies in a number of states that have already seen drops in enrollment, I think up to 20% in some states because of the chilling effects of the proposed rule. So even though I think WIC is a good example of a program that obviously many families rely on, and upon hearing that there, even after an assurance that there are that the rule would not apply as proposed to WIC receipt of WIC benefits, families are still choosing to disenroll because of that fear.
Okay, thank you. So either Dorothy or Laura, whoever wants to field this question, for administrative requests, is it correct that the request must come from a law enforcement agency?
It does not necessarily have to just come from a law enforcement agency. It actually can come from any administrative agency. So it's not just immigration officials or immigration agency. It can come from any administrative agency.
Okay, great. And so if you're speaking specifically about HIPAA, I'm not sure if the person who was asking the question was talking about HIPAA, but under HIPAA, a law enforcement official is defined as an officer or employee of any agency or authority of the United States, as Dorothy said. A state, a territory, a political subdivision of a state or a territory, or an Indian tribe, who's empowered by law to investigate or conduct an official inquiry into a potential violation of law, or prosecute or otherwise conduct an administrative proceeding. So hopefully that answers that question. And a follow-up for Dorothy and Laura. Do sensitive locations include religious congregations that are providing sanctuary to immigrants?
I believe that, in my knowledge, I do believe that it does cover religious organizations, or say church, So it does cover that. I'm not exactly sure to the rest of that question whether or not if they're a sanctuary, if they're providing sanctuary to undocumented immigrants, how that factors in. But I do know that the civil location policy does cover churches.
Great. Yeah. So the ICE memo does say churches, synagogues, mosques, or other institutions of worship, and it also includes the sites of a funeral or a wedding or other public religious ceremony. So I assume that the sanctuary part of the question actually adds additional protections there to that definition. Priscilla, another question for you. Did the 200,000 or so public comments that were submitted in response to the proposed public charge rule change have any effect at all, to your knowledge?
Thank you for that question. So, yeah, I did not, just to give a little more background to other individuals on the webinar, there was quite a campaign effort by the Protecting Immigrants Families campaign for organizations and individuals to submit comments in opposition to the rule. Initially, the target was to have 100,000 comments submitted, which we thought was a pretty lofty target, and we blew that out of the water with over 220,000 comments submitted, so that's fantastic. Right now, we are, I don't think it's a secret to say that the campaign and all of us who oppose this rule change are basically trying everything we can to delay implementation of the rule and block it if it does become finalized. We don't know exactly what DHS is doing. We know that they're in the review process. At some point, it will have to go to OMB for review, at which point there'll be a public notice about that, at least, so that we'll know that the rulemaking process is getting ready to move forward on the next stage to the next step. But we don't know exactly what impact the 200,000 plus comments have made. Part of that strategy of delaying implementation of the rule is certainly, both not just the quantity of the number of comments, but also ensuring that comments were individualized and made a little bit more. There were templates available, but I think all of the organizations and individuals have done a really great job of making sure that the software that DHS uses cannot simply just categorize. Our understanding is it'll kind of pre-screen comments that are submitted, and if there's a portion of the comment that is identical, they will basically just sort of clump those together as one. So we made sure that didn't happen. And then there's also, of course, was a lot of thought and strategy put into the content of the comments themselves in terms of anticipating possible legal challenges if it were to be finalized.
Sure. Okay. Dorothy or Laura, this is a question about information that's obtained in violation of HIPAA being used in deportation proceedings. Obviously, there's a fair amount of indignation about that. So how can we prevent this from happening? So how can information that was obtained in violation of HIPAA be prohibited from being used in deportation proceedings? And to your knowledge, are there any states that have placed protections over this information so that it's treated as it would be treated in a criminal proceeding?
Carrie, I'm going to take that question. That question is actually more of an immigration law question, which is slightly outside the boundaries of Laura and Dorothy's expertise here. And my modest amount of experience working with my colleague in the immigration law clinic here tells me that there is little to nothing that can be done about it. It is a federal tribunal. It is actually an administrative tribunal and not even a judicial tribunal. And so other than getting the rule changed, which I think would be a monumental task, there is little that states or local jurisdictions could do. I do know that there has been some work in the immigration law field, and maybe even Priscilla knows more about that. But folks who are working to fight against this, but the law is pretty clear about it. Unlike the rest of us that are protected in criminal proceedings from material obtained from us outside the boundaries of the law, immigrants do not, are not protected in that way in these proceedings. The one thing I'll say is, for folks on the call is this is why it's incredibly important for our healthcare professionals, those who work with our local health departments, with our state health departments, or independently, to understand the parameters of the law so that they are not sharing this information outside the boundaries of HIPAA. So to that end, obviously this webinar, but likewise the network will be publishing other materials on this soon. They'll be on our website, and we are available to help folks either with individualized trainings or providing technical assistance on this question. So it probably starts with doing our very best to make sure that HIPAA is not violated in the first instance.
Thank you, Kathy. So I think we have time for one more question. And as Kathy said, if there are follow-up questions or other technical assistance that needs to come out of this webinar, we're ready to provide it. So please feel free to contact the Network for Public Health Law through the website in order to ask any follow-up questions, and we'd be happy to do that research for you. So to finish up, Priscilla, this last question is for you. Are you aware of any class action lawsuits against the public charge rule change? I think you already answered this question about its status and the expectation of its progress. But are you aware of any class action lawsuits or lawsuits against the rule change?
So there is a very active litigation committee that I am not a part of, but Sarah Grusin, who is my colleague in our North Carolina office and is a litigator, is a part of. And so, yeah, certainly litigation is one of those tactics and strategies that groups have anticipated as being potentially necessary to block implementation of the rule. And there are current efforts to plan in the works in terms of planning for that and identifying plaintiffs. So if you actually do know somebody personally or within your network who might be interested in knowing more or being connected with a litigator who might have a story that you think might be reflective of some of the potential harm, obviously we won't know until the rule is actually finalized to determine whether that person will actually be harmed, but those efforts are already underway.
Carrie?
I just saw that we have until 2:30, so we can actually take the rest of these questions. There's actually only a couple, so we won't have to keep our our speakers on the line much longer.
Hey, Carrie, it's Kathy, and I have one that can I just cover one thing as well since we have extra time? The one thing that I wanted to remind folks is that you may have a state law that governs the confidentiality of your medical records. And so while that can't provide additional protections in immigration court, they may provide additional protections. And so most state laws are, consistent with the federal law, but you should also take a look at your state law. And then I have one more comment if there's time, but I'll wait and go ahead and answer the question.
Kathy, you should go ahead with your comment. We have time.
No, go ahead. I'm talking with the students about it. Sorry.
All right. So, Dorothy and Laura, this one's for you. The question is relating to the summary of the potential privacy and tort claims that are available to undocumented immigrants in state law. But the question is, as a practical matter, how would someone being deported be able to bring such a claim and have it resolved in a timely manner before adverse action occurs against them? I think the question subsumes the answer, but do you want to take a crack at it?
I can. Well, that's a great question, and that's something that we've definitely grappled with in the sense that there are many barriers for an undocumented immigrant who is facing deportation to also bring state tort claims or any type of lawsuit against a medical provider who violates HIPAA or any other patient privacy laws. I think, again, going off of what Kathy just discussed, in the sense that this is the reason why we wanted to do this presentation, because there really are no really great options for a person when their information has been sent to immigration officials and they're facing deportation. So that's why we really want to teach medical providers and other people within our field and explain to them the importance of keeping that information confidential, and to ensure that it doesn't get to that point where they're kind of faced with limited options for seeking remedies for when their information is violated and given to immigration officials.
Great, thank you, Dorothy. Priscilla, this question is for you. Is it important for local public health agencies to refrain from encouraging immigrants from accepting benefits without first encouraging them to seek legal advice about its potential impact on their immigration status?
So, I think there are, I would say first and foremost, the most important message is there have not been any changes to the current rule. And so our message has been that people who are already enrolled in benefits that might be impacted under the proposed rule or thinking about enrolling, we actually encourage folks to continue to do that because they need the services, they need the assistance, they need to survive. Once the rule, if the rule is finalized, there is still a 60-day period before a final rule will go into effect. And so there is time to notify individuals if they might be impacted. There's already been a lot of media coverage and hundreds of community-based organizations and legal services organizations who are already connected and educating folks in preparation for this. So I would say that public health agencies, enrollment assisters, anybody who really interfaces and gets these types of questions, I would encourage them to reiterate that message of continuing to use the benefits that you have. I certainly, it's interesting that you bring up seeking legal advice from their immigration lawyer. We also encourage that. I think one thing that has been maybe a lesson learned for many of us is that immigration attorneys don't always have as much knowledge or understanding about public charge as it pertains to eligibility, and even though eligibility hasn't changed, it's a confusing area, and so I think there are some efforts underway. I know, for example, in Massachusetts, there's a legal organization there that is trying to do more education, specifically targeting immigration attorneys to help them understand and come up with a way to evaluate whether receipt of public benefits under the proposed rule might trigger a negative public charge determination. So that education needs to be happening as well, and is starting to happen among immigration attorneys.
Thank you, Priscilla. So a question, this is a HIPAA question for Dorothy or Laura, regarding the role of public health officials. So there's a specific kind of hypothetical that's posed here, and so I will read it to you. So for example, another local health department informed us of a disease investigation case that they were working on. In this situation, a client's visa had expired, and this local health department reached out to immigration to revalidate the client's visa. So I assume that means to make sure that the visa was valid, or to make sure that the visa got revalidated. Did this local health department violate HIPAA by reaching out to immigration? What should have the local health department done to assist the client with renewing their visa while still being HIPAA compliant?
And so that's actually a great question. We believe that it is likely that they may have violated HIPAA in the sense that they did give protected health information. So as we went over in our presentation, an immigration status alone would not be protected underneath HIPAA. However, giving the patient's name, their immigration status, and that they were seeing them, that would all be protected underneath HIPAA, so they likely did violate it. However, there may be some gray area in the sense depending on, did the immigrant patient ask them to intercede on their behalf? I guess that might be a question. I know that that hypothetical didn't address that, but they may kind of be a little bit more of a gray area. But if there was no authorization, then they likely did violate HIPAA.
Thank you, Dorothy.
Getting consent from the individual would be what, would solve that problem. If a local health department wants to be that engaged with their patient, they certainly can do so within the confines of HIPAA. They just need to make sure that they have authority to share the information.
Exactly. Awesome. Okay. So, Priscilla, one last question for you, I think, unless folks want to type a question into the Q&A bar. We do have some time. To your knowledge, Priscilla, is there a quick way for folks to find out if states have removed the 5-year bar? For example, a website with a 50-state chart or the like, or does the network need to take that on?
So thankfully that is something that currently exists on the Kaiser Family Foundation website. I believe they update it annually, yes. And the National Immigration Law Center also has really, really great resources. That's actually my go-to place because there you can, as lawyers, we always want to see the citation. So they provide very detailed citations and go into more detail about the state options.
That's excellent. Thank you. So I don't see any other substantive questions. So do any of our panelists have any last burning thoughts that they wanted to share that they didn't get to say, or questions that they wished we had asked them?
Carrie, this is Kathy. I just wanted to tell folks that we did this presentation last week to a local health department here in Maryland. Actually, you are well aware of that, Carrie, since you were with us. I just wanted to, most of the questions that were asked at that event were answered already in the presentation. But one issue that did come up was the question, we're talking about health professionals here, and they said, wow, this is scary. Like, how, I know you're walking me through all these things that have to be on a subpoena, but how will I know? Like, how will I know if it's legit or if it's not, or what have you? What we learned kind of on site was that there is a process within their health department for any of the health professionals working for them and any of their clinics or otherwise. They go actually to the deputy health officer, and he has a direct line to their attorney at the Maryland Attorney General's office. So what they're to say to the individual presenting the subpoena is, you're going to have to wait. I don't know how quickly I'm going to be able to get you an answer. You might have to come back, but hang in there. And then they go through the process, and the Attorney General usually can pretty easily say yep or nope. It does meet the standards and it is legitimate or not. And so that was, I thought, helpful. Those folks found that particularly helpful to know that they weren't going to have to resolve that particular issue. The same question came up for, well, but what about our private practitioners, folks who are in a small medical office who don't have that ability? And I think, that's a legitimate question that, the Attorney General's office is doing this on behalf of state entities, which our local health departments here in Maryland are technically state entities. But hopefully they have access to counsel who can help them with that determination. And then the other point that was kind of brought up as a result of that conversation was to make sure that when you do respond to a properly issued request for documents, you look very closely at what is requested and that you redact. You don't just like, oh, I'm just going to copy the whole file and send it over, but that you look very carefully at what is requested and only respond to what is requested in the subpoena. And if you have to redact documents, meaning I think we all know what redaction means after last week, but if you have to redact documents, you just want to make sure that you are, completely covering up the information that you're not intending to share. The best thing to do is to actually copy the version that you marked out and use and give the individual the copy, because that is like a double check on making sure that your redaction took place. So again, the two things to remember, how do I know this is legit? Seeking out either your local or state level public attorney, or if you're in private practice, seeking out whatever attorney your office uses, and making sure that you're responding just very narrowly to what has been requested. And that's it on our.
This is Priscilla. Yeah. And this is Priscilla. I would just underscore from my end that, this is still a proposed rule, but we, groups and folks on the ground are working really hard to start to educate communities and immigrants and families. There was a dramatic decline after 96 per when there were the changes to the qualified and not qualified categories, and it took many years to really build up enrollment into Medicaid and CHIP again. After that, I think we're sort of in the same place, even though the proposed rule hasn't, the rule is still a proposal and hopefully will not be finalized or ever be finalized. But, as I've shared, the chilling effects have already had an impact on disenrollment for impacted programs and also programs that are not impacted, such as marketplace coverage. So, we just need to keep talking about this and helping folks understand, what and dispel some of the myths around this. Thank you.
Absolutely. Thank you, Priscilla. So we did have one more question come in, and this really is for any of our panelists. Are any of you aware of any positive examples of medical health centers who model a protective relationship with their patients? And if so, what might that look like?
No, but that's
Okay.
I'm not exactly sure what they mean by protective relationship. Yeah.
I mean, the one thing that occurred to me, Dorothy and Laura, when we were talking about with the immigration professor that we've been working with on this project, about different things that medical facilities and providers can do to protect folks that are visiting them for preventive care or treatment, in order to create that expectation of privacy, to really, kind of invoke those Fourth Amendment rights there, and also to just create more of a sense of trust and, kind of counteract that chilling effect that Priscilla was talking about. And some of those things were, you know, putting signs up in the waiting area that say for patients only, you know, those kinds of things where it's very clear that there's an expectation there that only patients and folks that expect to have that relationship with a provider are in that space and in that area. Because there was some question about, you know, waiting rooms being, you know, different than the actual examination room, for example, and that kind of helps to get rid of that barrier. I don't know if that's the kind of thing that the person who asked the question was talking about, but those are the kinds of things that we've become aware of through this research. So I don't know if anyone had a follow-up to that.
Can I add something to that?
Yeah, please do.
Just because, so I'm based in California, and California had enacted SB 54, which is our state sanctuary law, which folks might know it was also challenged by the Department of Justice. But as part of that, that law, the state is required to develop model guidance and policies for courts, schools, and public health centers in terms of how to, you know, it's not enforceable. This is just guidance, but what's helpful, we provided some input on the development of the health one, which is very much centered on creating these safe spaces and understanding you know, the differences between administrative warrants and other types of warrants, and provide examples of all of these things in a packet that is designed for both frontline. I think a lot of it is actually targeting frontline staff, but also health administrators. So hoping to provide some tools to help implement some of these policies from the perspective of the provider. So those are available on the Attorney General's website for California, and I'm happy to share the link to the presenters, and they can send that out. But that might be a model to look at.
Great, thank you, Priscilla. There was also a question for us to please share the link to the resource on the Kaiser Foundation website. So I just Googled Public Charge Kaiser Foundation real quick and put something in the Q&A. But if you wanted to share that link with us as well, we can you know, make that available. There was another question about where the slides can be accessed after the webinar is over. They will be posted on the network's website along with the audio. On the website is www.networkforphl.org. If you just search the webinars tab, you should be able to find it. I don't see any other questions. Lots of great feedback in the Q&A. So please join me in thanking our panelists for their presentation today and for this great information. Any parting words from any of our panelists? I know I've said that already, but now I mean it. Okay, great. Everyone, thank you for attending this webinar. Thank you for your time, and thank you for attending. And oh, there's the link right there on the slide of where you'll be able to access this in the future. So again, thank you, everyone.
Wrong link. All right, let me send it again. Okay.
Thank you.
All right, thank you, everyone. Bye-bye. Enjoy your day.